David Wallace with PV Reporter.
Nice to meet you.
Yes, and Dr. Gisslinger, we're here at ASH 2014 in San Francisco. And you're from the Dublin Hospital?
No, I'm from Vienna, Austria.
Okay.
I'm from the University Hospital of Vienna, Medical University of Vienna. And I'm a member of the Department of Hematology and Hemostasiology. And I'm working since, in the meantime, more than 30 years in the field of myeloproliferative neoplasms. I started my clinical research actually with interferon back to 1984, so it's exact 30 years ago when we treated our first MPN patient with interferon. At this time it was recombinant interferon alpha 2C, later on 2B. Which was certainly not pegylated, and we treated the first patients in the world with myeloproliferative neoplasms with interferon. And we were focused initially on thrombocytosis, and we could see, for example, that platelet count go down very fast after initiation of interferon. Some patients had a normalization of platelets counts even after 3 days of interferon treatment. But at this time we used interferon on daily basis, so they had to inject it daily. Therefore the side effects were quite high. And also the dose we used initially were 10 mega units per day, so it was a huge dose. We saw also a decrease of white blood cell counts, which went very fast, and we had the impression that red blood cells take very long until they decrease. Therefore, we focused on platelets and white blood cells, and did not focus on red blood cells. And then Richard Silver introduced the interferon, especially for polycythemia vera, and this was the birthday for interferon in PV. But in the meantime, we continued to use interferon for our MPN patients, and we have many patients who are interferon users for more than 20 years in the meantime. And later on, when it was available, we used pegylated interferon. Initially Pegintron, later on Pegasus, and in the meantime we have many interferon-treated PV patients, but also early myelofibrosis patients during long time, and so we can reduce the dose after a longer duration of the treatment, and usually interferon works excellent in these patients.
Okay, and you've hit a key point when you mentioned the dose reduction. I know myself as a patient that's taking Pegasus, I'm on a weekly dose. So one of the things that I'm excited about, and I know that our readers will be excited about, is the reduced frequency of dosing, and that's with the AOP 2014. Can you tell me a little bit more about the reduced dosing and possibility of less side effects?
Yes, the AOP 2014 is a pegylated interferon, proline pegylated interferon, which has a larger molecule with a longer half-life, and so we can administer this subtype of interferon every other week. So initially we use it only every other week, not weekly like the other compounds. And the interferon is very well tolerated, and it's very active because we have a more even plasma level, even up to 2 weeks. And during our first study, which was a phase 1, phase 2 study, so a dose escalation study, we saw that many patients achieved complete or partial remission, so about 95% of the patients had remission. And in those patients where we did achieve complete remission, we switched from the 2 weekly intervals to 4 weekly intervals. And we could see that during this reduced dosage of interferon, you can see it on the poster today, that there was the monthly interferon dose was reduced from more than 400 to a little bit more than 200 microgram per month.
Okay.
So it was just 50% of the dose, and we could continue the remission rates, the partial remission as well as the complete remission, concerning the hematologic response as well as the molecular response.
And let me ask you this, Dr. Gisslinger, how do you know which patients are good candidates to go from the 2-week to the 4-week dosing schedule?
Okay. We selected the patients according to their response, so only the patients who did achieve complete remission, hematologic complete remission, were switched from the 2 weekly intervals to 4 weekly intervals.
Okay, very good. Can you give us a time frame for when you think this drug will be approved and ready to move forward for MPN patients?
Okay, this is a very difficult question for me. So it will take time because it will be registered in Europe by the EMA, maybe 2017, we will see, maybe 2018, but they hope that they can make it until 2017.
Okay.
And it will also present it to the FDA in the United States with this randomized phase 3 study named PROUD PV study. And we will see, we are now almost ready with the recruitment of the patients. There's 260 patients planned, and we will very soon achieve this goal. And then we have to collect an observation time for all the patients for at least 1 year during the study.
Okay, so that's why it's not quite as fast as maybe we hope.
Yes.
Okay. Do you have any information as to the efficacy in mixing the interferon with ruxolitinib in patients that are either CALR mutated as well as JAK2 positive? Do you have any information on that?
We have some observation on the response of calreticulin allelic burden, because calreticulin, as you know, was discovered in Vienna, and we had certainly several patients who were CalR positive and already started with interferon, so the CalR allelic burden is going down in some patients, but not in all. And I think we are using also a lot of ruxolitinib in myelofibrosis and start now to use it in PV patients. I think each compound has its advantages and disadvantages. As you know, interferon is not well tolerated in some patients, about 20% or so don't tolerate it because of maybe autoimmunity or mood disturbances. On the other hand, if we use ruxolitinib during a very long duration, there is a certain risk for infections, viral infections, for example. And so ruxolitinib might alterate a little bit the immune system, and on the long run this could cause some problems. For example, if we mix or if we combine these two compounds, it could be possible that both the side effects of both compounds can be avoided by the combination partner. For example, interferon is good for preventing viral infections. And on the other hand, we know that ruxolitinib might have some effect on autoimmunity and also on the mood, because ruxolitinib patients feel very well. So the combination seems to be very attractive, and we have some first reports about the effect of this combination, and this looks very promising. So I think on the intermediate development, not now but later on, this combination could be a very promising, but we have a lot of clinical development and clinical research in front of us.
Okay. Well, we certainly look forward to hearing more about AOP 2014 and your research moving forward. And I want to thank you, Dr. Gisslinger. And this is David Wallace with PV Reporter, reporting from ASH in San Francisco 2014.